Hello and good morning, everyone. My name is Morgan. I'm for you to be here. Got Hiva in the chat this morning, and we are going to get started here in just a few minutes. And we are going to be talking about all things obesity. I'm going to give just a couple more minutes for people to come in, but just to get going, I wanted to just tell you about some of the cool and new exciting things that we have at Archer in case you don't already know. So we've started this new thing. It's called Sure Pass. It includes kind of everything that you need to go ahead and just get started and pass your boards. So if you haven't already scanned this QR code, it's so incredibly helpful. It's a pass guarantee as long as you're scoring within a certain range before you sit for your exam. It's going to tell you and make you just feel really confident that you're ready to sit for that test. Um, so it includes the Q bank. So that is a lot of questions. And I always tell patients, no, I always tell students that the best thing you can do is just lots and lots of questions so that you practice how best to understand and um, uh, understand and approach questions on your boards exam. And then it includes the on-demand videos. That means whatever questions you kind of stumble on, you can go back and watch that content. And finally, the live review. So we have a live review coming up here in mid-November, and that is a 3-day intensive course, just high level of all of the topics that you need. That is with me and Shiva and a few other colleagues. We just give it to you. It's quick. It's a great review. And then with the SurePass, you get all of that kind of included. So it's super helpful. If you're not already, I encourage you to join our Facebook group. We have a lot of really good information that kind of goes through that. And it's lots of students just supporting other students. All right. I always tell patients, I keep saying patients. I do work in a clinical setting, so that word just comes to my mind. I always tell students if there's something that I miss speak on during today's lecture, if there's anything you have more questions about, please do not hesitate to email us here at nursepractitioners@archerreview.com. We want to make sure we're giving you the latest and greatest of all information. So please let us know if there's something that we are saying that is maybe not the most evidence-based any longer. As we know, medicine is quickly changing, so that's changing. All right, without further ado, we are going to jump right into obesity management because that is what you all came here to see and talk about. Again, I have Hiva in the chat, so any questions that come up, please share. I will try to make this interactive. I am not going to pretend that I'm great at that, but if you have questions, I'll try to get to them, or Hiva as well is here to support us. Okay, so today's objectives, what we really want, what I really hope that you get out of today is that you feel a little bit more confident in managing obesity, talking about obesity with patients in the primary care setting, and that you kind of have a little bit idea how we define obesity, where we've come from in healthcare, which is quite a ways, why we care so much about it, given the epidemiology, and then also the comorbidities and complications that are associated with it, how one develops obesity, what we think is going on, how the body regulates itself, and then again, what we do about it as primary care clinicians. Okay, so when we think about the history of obesity, I really want to start off kind of going over this evolution. We have seen so much change in the past few decades in medicine and how we as clinicians think about and approach obesity. So in the not so distant past, the medical community, we really oversimplified this condition. We used to really think about obesity as a consequence of an unhealthy lifestyle, just that imbalance of energy intake versus energy expenditure. We simplified it down to an equation where we were just trained that this was a reversible condition. If we could only get our patients to just change their diet, increase their physical activity, we would help them lose the weight, and that would be it. Unfortunately, even when patients did lose the weight, it was really hard for them to sustain that. And when they came back to us, we kind of shamed them. We kind of put them into a bad state. We created some bias. We created a not great relationship between patient and provider. We felt like they failed us as their provider as well as failed themselves. And goodness gracious, that was not the right way to approach this. However, thankfully, we've really kind of expanded our understanding. Researchers really question this theory of just like willpower and caloric intake. And since then, we know so much more about this crazy complex disease, and therefore we know how to approach it in a little bit different way. So back in 2012, the American Association of Clinical Endocrinology gave us a description of this the complex pathophysiology of obesity. They saw that there was like an interaction going on between genetics, biologics, environment, as well as the behavioral factors. Okay, so with this new description, obesity now fit AMA's criteria to be classified as a disease. Okay, Obesity Medicine Association took that and they created a definition for us, and that's what we currently use. We think of obesity as a chronic, relapsing, yet treatable, multifactorial, and neurobehavioral disease. This increase in body fat promotes adipose tissue dysfunction, and it leads to a metabolic, biomechanical, and psychological adverse outcomes. Okay, so this technical change might seem small to you, but really what it has done is open the floodgates into further research and investigation into both the etiology and the way that we manage obesity. So we really, really do care about it. For now, we know that obesity is related to a number of other chronic conditions. You can see the list here of these chronic conditions that obesity is related to. We also know that a 16 to 20% reduction in body weight for a person with obesity can reduce the obesity-related health complications. And most importantly, it can really reduce the rates of premature mortality or death. So it does matter because this is what we are setting out to do. All right, with that being said, research also tells us that a person can lose on average between 5 and 10% of their body weight through calorie restriction and increased physical activity. We know they can do this. It takes about 16 to 26 weeks. The problem is this is seldomly a sustained weight loss because we know that there is this complex biological mechanism kind of at work, at play. We know that it's really, really hard for folks to maintain their weight. So just a quick brief guide, as anybody has been in any of my lectures before, you know I love statistics. So I'm going to go ahead and just give you a few statistics just to kind of tell you why you should care about this. Okay, so when we think about the prevalence of obesity in the United States, we kind of understand that this is something that's pretty darn common, and you're going to see this in primary care if you haven't already. All right, it's pretty ubiquitous as well. It affects about 52% of all Americans, with the highest disease burden really afflicting our Black American community. We also know that income level and education level are described and have a correlation along with obesity, which makes sense as we're kind of thinking through some of these things. You guys, these statistics here are from 2017, 2018, kind of some of the most updated statistics I could find putting together this presentation for you all. However, what's projected to happen by 2020 is that we will see obesity rates increase to about 68% of Americans. That's huge, 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 huge. And that just tells us that this is really going to carry a huge burden, not only for patients, not only for families, but this is going to burden our healthcare system quite a bit at 68%. I don't think we're going to get there. I'm very optimistic. And I think that these interventions that we have now and having this description and having all of this science that's coming out, these medications that are coming out, I'm very optimistic that we are not going to see that go up to 68%. And I am hopeful that we're actually going to see that number from 52% come down. And you guys are critical in making this happen. Because as primary care clinicians, we're going to come in contact with folks that have obesity time and time and time again. And I'm hoping that you feel ready to address this with your patients. Okay, so when we think about body weight, we think about body weight regulation. It is a complex thing to understand, okay? We think about energy balance and then all of these adaptations that our body makes over time to maintain whatever weight we sit at, okay? Um, Scientists really describe energy balance. They consider three states of energy balance. They consider the negative energy balance, balanced energy, and then also positive. Okay, so in a negative state, you're thinking about a fuel shortage. So we're thinking about a calorie deficit. And after a prolonged period of time, that person who has a calorie deficit, their body enters a starvation mode in which it begins to preserve calories. Okay, then we go to a balanced energy state. That's when our anabolic and our catabolic rate, or our intake and output, is roughly equal. Okay, and then positive state, well, you probably know what a positive state is. That's what we're here to talk about. That's when we have an excess of energy or calorie intake in comparison to our calorie or our energy expenditure. So we know that being in this positive state over time is what leads us to weight gain and increase in adiposity. But what we don't quite know, and what we're going to talk about today, is why we're there. How do some patients or some folks get into that positive state? Well, we know it goes beyond the willpower. It goes beyond just physical activity, right? We've all heard our patients, I eat just salads and I'm working out and I still can't lose weight. Or maybe they do lose that weight. The moment they like loosen the reins just a little bit on their diet, zoom, they go right back. We think that there's some things, these metabolic adaptations, one being adiposity homeostasis, where the body is used to a certain level of energy reserve and therefore is going to do everything it can to get back there. All right, next slide. This is kind of a little bit of a lots, kind of shows us all of the factors that come into play that kind of lead us to a point of positive energy balance. So what we really think, and what research has shown us, is this understand to begin to understand obesity as a multitude of factors that kind of come to play, which some of them we can address, right? Some of them with lifestyle and counseling and talking with our patients, we can address some of these things, but some of these things are completely out of our patient's control. They're out of our control. And we think that there's like some genetics, some developmental things, some environmental factors. All of these things come together to cause that positive energy balance that ultimately leads us to weight gain and obesity if extended over a period of time. Okay, what I found it super fascinating and I wanted to share with you is this kind of emerging research around endocrine disrupting chemicals. So you probably, maybe you haven't, if you're not like me dorking out and reading about all this stuff all the time. But they're in the press a lot. Endocrine disrupting chemicals are thought to really interfere with the hormone action, and it dysregulates adipocyte function. It dysregulates insulin signaling and overall endocrine function. So our body talks to each other through hormones that are going on. And then we have these chemicals, maybe applying them to our skin, might be getting them through plastics. Who knows where and how we're getting them? But the scientists believe that these chemicals may be disrupting kind of some of that programming of our appetite and satiety. And it might just make it kind of seem like our patients aren't receiving. Like, if we break this down a little bit, patients might not be receiving the correct hormonal signaling that they're hungry versus thirsty versus full, which can lead to some overeating or that positive energy state. So we have a lot of things that we think about that are coming in here. Um, some of these environmental factors that all come into play. We think of the gut microbiome, that's been described a lot lately, that might be contributing to somebody's positive energy balance. Also, what medications are we prescribing, right? We know that certain medications are going to increase somebody's appetite and their metabolic state will be disrupted at that point. Okay, so why do we care about this? As I mentioned earlier, obesity is linked to a lot of chronic serious serious chronic diseases. And the disease burden is very high. Like I said, it's not just on the patients and families, but it's going to be high on our healthcare system. If we get to that 68%, we are going to see a ripple effect from all of these other things that are contributing or related to obesity. All right, this is not an exhaustive list here, but it shows some of the most critical comorbid conditions. So biomechanically speaking, we see an increased risk of orthopedic abnormalities. We think of like osteoarthritis. We think of somebody with just balance concerns, right? And the risk of falls. We think of sleep apnea and that kind of all of the things related to sleep apnea, hypertension, all of those things that can kind of come into play. And somebody's ability to just function, okay? On a psychological level, folks with obesity can experience higher rates of things like depression, hopelessness, low self-esteem, body image dissatisfaction. And then something that's really important is at work, we have studies that show that people with obesity, they have lower hiring rates and they're at a higher risk of termination. So then when you think about their ability to care for themselves and go beyond that, when health insurance is linked to employment, when income levels and food availability, all of those things are going to come into play. And then with that psychosocial and that depression and all of that, it's all a big kind of cycle we can start to see here. Now let's talk about our role. So the healthcare bias. We talked that we have kind of evolved or we are evolving. However, this is still super prevalent in the healthcare setting. And when we talk to patients with obesity in a research way and that kind of more qualitative evidence, we are hearing that they still feel pretty stigmatized when they're accessing care. So the provider's their attitudes, stereotyping our patients with obesity, it affects that relationship. And really the decision making is really compromised. Care is compromised. When we have these poor interactions between a patient and a provider, we think of mistrust. We think that they're not going to be adherent to any of the recommendations that we're making. They may avoid something that might be necessary. So some of those screening things that we want somebody to do. Now, if they don't trust us, if we've stigmatized them, if we made them feel bad, they're not going to trust that when we say they need a colonoscopy or a mammogram or a pap smear or any of those screening tests, they're not going to come in and feel confident to access those services if we continue to put this barrier between them. And then metabolically speaking, guys, here we see an increase, which isn't surprising, increase in the prevalence of type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, as well as cancer. All right, something really important here, just a statistic I wanted to share with you is this correlation between the class of obesity. So remember we talked, well, I don't think I talked about it yet. I will talk about class 1, class 2, and class 3 obesity. So when we think about folks with a BMI between 55 and 60, there is about an estimated 14 years of life that is lost because directly related to that state of obesity. All right, another fact that I found completely astounding when I was studying all of this material is the established link between body weight and cancer. All right, this pathophysiology is really thought to be that the fat cells induce an oxidative stress and increase inflammation in the body. This inflammation leads to increases in malignant dysplasias, hyperplasias, proliferation, and metastasis of different cancers. And there is a direct link between 13 different cancers. And a few of them, just to give you a few things that we have related body weight to, is esophageal cancer, gastric cancer, colorectal, liver, pancreas, breast, endometrial, ovarian, thyroid, multiple myeloma, all have been linked to body mass index. All right. So these cancers, so obesity-related cancers account for about 40% of all the cancers that we have. So I'm going to make out the argument that when we're prioritizing weight reduction with our patients, we are in fact providing a preventative approach to something like cancer. And so I think as PCPs, it's 100% our duty to address body weight and these things in our primary care offices. So how do we go about doing that? Okay, so as primary care clinicians, our goal is our patients to improve our patients' health, maintain their health, improve their quality of life and their function, right? And the other things we really want to think about is when we're talking about weight, is how can we um, reduce the risk of some of these diseases that are associated with obesity when we're talking about improving their overall body, composition. So how their body is made up. All right. When we the way that I approach this, and you guys can choose your own ways to go about this. I'm just going to give you my kind of the way that I go about approaching weight and obesity in my practice. It's, again, completely my style. You can choose your own. But I use the annual exam. If you've listened to any of my other lectures, I use the annual exam as a way to open doors to different health concerns that I may have with my patients. So, um, during that time, I know I can't address their weight, but I can start the conversation here. Okay. And then I can bring them back in for a follow up appointment. So, the way I'm going to do this is I'm always going to ask for their permission to talk about their weight in regards to their health and the concerns that I have around that. If they give me their permission, then I say, there's a lot around weight that we're just learning about. Okay. I want to have this conversation with you. And if you're open to it, I would love for you to come in and see me and let's talk a little bit and let's just focus on that one specific thing because we have way too much to cover today. And I'm only given 15 to 30 minutes, depending on where you work, to really get through that whole annual exam. So it's a moment of pause, right? But we're going to have this conversation. We're going to say we're concerned because it's our job to tell patients when we're concerned, and we're not going to be worried. We're going to be very compassionate. We're going to be very kind when we're having this conversation with patients, and we're going to work very hard not to create a barrier, but introduce this as a concern. And I can guarantee I've had very few patients get upset with me addressing this. Most of them, yes, thank you, but they don't know how to bring it up. So bringing it up is important. All right. Um, when you bring them in now for that follow-up appointment, oftentimes I tie it with their labs. So during that annual exam, I'm getting all of their labs and I say, why don't you come back in? We're going to talk about all of your lab results. And then we're going to talk a little bit about healthy weights and stuff like that and things that we can do. We know a lot. So let's have this conversation. Okay. So when they come in, I go ahead and I give them a questionnaire ahead of time. So we've already preface that this visit is prioritized on weight. And so I give them a questionnaire that I can ask. I've created one for my own clinic where I ask about their weight history, their dietary history, medications. Are we prescribing something that's causing them to gain weight? Family history, socioeconomic status, education level, social history, mental health history. Is there a history of an eating disorder? And that includes binging and purging, laxative use. Have you ever been diagnosed with anorexia? Those things are so important to understand because now we can be extra careful in how we are going to approach weight loss with this patient. Okay. For their physical, the BMI and waist circumference, neck circumference can be really indicative, especially if we're concerned about something like sleep apnea, blood pressure, heart rate. And then with labs, again, I most of the time get these during that visit prior, so we're going to talk about them. But what I'm really thinking about is their overall metabolic state and things that we need to consider. With certain folks, you may need to get a little bit more studies, things like an EKG, echo, stress test. Do they need a sleep study? Do you think there's like a sleep apnea occurring? Are they swallowing okay? All of those things are going to be important and kind of more specific to certain patients, but those wouldn't be out of the normal to order. Okay, so classifying body weight relative to health risks, it is important. And having some objective data can help us know that we're making progress with our patients, right? I, in my practice, use mostly just BMI and waist circumference for my objective data. However, I'm really, really critical to let my patients know that these numbers are not my focus. My focus is on a multitude of factors that, as we move through these weight loss journeys mean more to me than these numbers. So overall functions and the reason why my patient is sitting in front of me and concerned about their weight and want to have these conversations, those are my priorities. These are just added things for my notes. Okay. I want to make sure, like, I have a few patients that they don't want to know their weight. They don't want to know their measurements, and that's okay. And I'm going to always honor that, right? So, what my patient is hoping to know and how that might trigger anxiety, might trigger certain feelings, I want to know that ahead of time before I have my MA getting their weight. Some patients will refuse to get that stuff done, and that is their right to refuse these things. But other patients are like, yeah, you can get my weight, but I don't want to know it. So what we do is we just have them step on the scale carefully backwards, or I measure their waist circumference. Make sure you always have a long enough tape measure, because the last thing you want to do is try to go around somebody's waist and not be able to fully make it. So make sure your tape measure is long enough to fully get around somebody's waist, because a lot of the ones that are given in healthcare, they're mostly for like legs and like when you're looking at inflammation or something like that, comparing edema. They're not that long. So go ahead and check yours at home and make sure that it's long enough so you're not doing that on the patient and have that embarrassing kind of moment where it's really just putting, again, some of that barrier between you and your patient. Okay. Again, I do use some of these things because they're our guide to how we can treat our patients, right? And what the indications for treatment is based on some of these things. Um, I have these conversations. So like with one of my patients, he refuses to get on the scale. That's totally fine. I honor that 100%. But what he did send is a photo of his belt, which was pretty cool. He had to buy a new belt, and he went down 8 inches over the course of a few months, probably 4 or 5 months, went down 8 inches and had to get a new belt. And so he sent me like just the kind of marks on his belt loop as his progression. And that was such a powerful moment for both he and I, in knowing that we're making some change. And it was really just an extrinsic motivator, because he didn't have the scale or any of these numbers. So everybody's different. Some people find the scale very motivating, others don't. I'm just saying, be flexible with it. Okay. And then again, we know that the AMA states that the BMI has limitations. That's why I go ahead and pair it with something else like the waist circumference. There are these other measurements that you can consider doing, that, depending on your clinic and if you have the access to that, but everybody has a scale, and you can get height, and also just simple tape measure for their waist circumference. You do it right at the umbilicus. Make sure you're not pulling it too tight. Okay. So moving on here, I'm just going to take a sip of water real quick here. I'm talking very quickly. Does anybody have any questions about what we've talked about? Because now we're going to kind of move into more of that management stuff, about the history, these counts that we use. Anything, everybody? Okay, we're moving forward. Okay, so moving on to the management, I explain, I really want to go over that the management includes conversations and changes around physical activity and helpful nutrition. But we're going to go a few steps beyond those things. That's probably what you already know, right? Obesity Medicine Association has given us these 4 pillars of obesity management, which include both that nutrition and the physical activity piece, but they also give us a tool of medical management. So we'll talk about that here in just a moment, as well as the behavioral modifications piece. Okay, so I think of behavioral modifications as kind of that mental health piece. So we think of the body in a holistic term. We're thinking about this. It is going to be very, very different for everybody. And I always tell my patients, this is kind of the last piece of the puzzle. I like this puzzle here. This is the last piece of the puzzle that kind of comes together. We really start off treatment talking about that medical management. So that's where the patients come to me, they've tried likely the healthful nutrition, physical activity. They've probably tried a few different types of diets. So if they're sitting in front of me, I kind of realize that we're going to jump into that medical management likely. Again, I just ask, why are we here today? What is it that you're hoping to get out of today's visit? If they already kind of know, a lot of people are going to come in and ask you for these newer medications or medications that they could potentially try or surgery, right? Do you think that I need surgery? So, apart from that medical management piece, we're going to talk about nutrition. We're going to talk about physical activity, and we're also going to have a big focus on that mental health piece. Our relationship with food, breaking old habits, maybe coping mechanisms. Again, this is going to look so different for each patient, and there's a no one size fits all here. We really need to listen, sit back, and this is going to be developed over time. You're not going to know everything about your patient in that one visit. It's going to be an ongoing conversation, and that's what I tell my patients, that we are going to really unfold some of the relationship around food. What has it been? What is it currently? Do you have that guilt? Is there all these different feelings that can be happening on an emotional or mental health piece? So it's so important. And I always tell new providers that you need to be okay with some of that silent pause. You're going to be having difficult conversations with patients, and they're going to need a moment to think about how they're going to respond to your question. Okay. And so oftentimes we ask a question, and then the patient takes a moment and we ask another question, or we provide an answer. What I'm going to challenge you to do is to sit back and really let your patient think of that. And I always tell patients, if there's anything that I ask you during today's visit that you don't want to answer, you can just say a hard pass, pass. Like that during annual exams as well. We get to some, personal information. If you don't feel like sharing with me, that's okay. You can say pass to any of these questions. So preface it with that, but give them a moment to think through their answers. Okay. Don't just feel like you need to rush through this. Be okay with that silence that may exist. All right. So we're going to start kind of from the basics here. So healthful nutrition. So I think about calorie intake, and something we can do. We definitely want to reduce the calories that somebody's doing. When we think about just your cisgender folks, we think of, like, for females between 1,000 and 1,200 calories a day as a low calorie diet. For cisgender males is between 1,200 and 16 calories per day. There is such thing as a very low calorie diet, which would be less than 800 calories a day. That is not anything I do in the primary care setting. If somebody were to want or need to be on that, that's a medically supervised diet that should be, referred out to somebody else to manage. With our obesity medicine friends, they can take care of that. All right, so we talk about protein intake. I think between 0.8 to 2 milligrams per kilogram per day. We also think a little bit about a fat restriction. Less than 30% of our total calories per day should be from fats. And then carb restrictions. I don't like any diet in which we're completely cutting out carbohydrates. They work. The moment you reintroduce carbohydrates, that weight tends to come on. So we have a reduction in these things, a reduction in intake. But that is something that we really have a conversation around. And then fiber intake, making sure that our patients are getting plenty of good fibers, 25 to 30 grams per day. And then we talk about fats. So I think my most exciting part of my journey with patients is reading labels on foods. Okay, so what I challenge my patients to do is just to kind of start looking at labels. I'm not saying changing decisions based on labels, just understanding what foods look like on their labels differently, and what kinds of things are in the foods that we just by habit are grabbing off the shelf. So what I ask them to look at is first just the ingredients. Can you pronounce what is in the foods that you're buying? Are there a bunch of chemical compounds that you can't even pronounce the names of? Are there, I think of something like maple syrup. When you look at a maple syrup label, is it really maple syrup or honey? Is it really honey? Or is it something like a high fructose corn syrup with some dye in it that gives us the taste of honey or syrup, but in fact is not anything related to those things? We may not know, right? We have grabbed what we think is maple syrup off the shelf for years and years and have never looked at the label. And we didn't know that in fact what we're eating is not what we thought we were eating this whole time. We're eating things that, like with that high fructose corn syrup, we use corn to increase the adiposity or the fat on our cows. So we know that that's going to automatically cause some kind of balance, metabolic impact on our bodies if it causes that probably in a cow, right? I think we can make that decision or that kind of correlation. Anyways, so what I tell patients to do is buy the bread that you do, but pull a few other breads off the shelf, okay? And look at it. How much added sugar is in that bread? What kinds of other things are in that bread? Yogurts, easy thing to do. Juices. How much sugar in comparison? We got to make sure that we're comparing, things. And this is again really important, knowing somebody's education and literacy levels, because you may see a little bit of a difference there. And so depending on their literacy levels, I might pull up some things on my computer with the patient sitting right in front of me and show them the labels of peanut butter. Okay. Here is Jif versus here is quote unquote, like, something that you think is organic and natural. Look at the labels on those things and compare a few brands, because it might have this amazing marketing, right? And in fact, it's no healthier than what you previously bought, or perhaps it is. So that's why I tell patients just to kind of start understanding how to read a label. And so I pull up a few of those things to really show patients how to do that. Unless, they're at a higher literacy level and they're already doing those things, then obviously that's going to be a little bit different. And then we talk a lot about fats. So healthy fats versus unhealthy fats. When we, not all fats are created equally. We think of polyunsaturated fats like our omega-3s, omega-6s, nuts, walnuts, almonds. All those things are giving us lots of really good health fats that help our body build, right? And then we have our monounsaturated fats, oils, avocado, olive oil, canola oils. Those are going to be our three that we should be cooking with and using versus like vegetable or corn oil. We had the hydrogenated oils, trans fats. Those were banned back in 2018, but we still do have the hydrogenated oils have been banned, but we still do have trans fats. Again, look at those labels. Those trans fats are associated with an increase in the low density lipid proteins. In our cholesterol. It decreases the good cholesterol, the HDLs, increases our risk of cardiovascular disease, diabetes. Certain cancers have been linked to things like margarines and some of those popcorns. A lot of the fast food things, we do have some links out there that exist. So something to just be a little bit more aware of. As far as diets go, again, I'm not a big fashion of the fad diet. I'm not a big supporter of some of those more fad diets. They do work, but they're hard to maintain. And so what I talk to my patients about is just looking at your plate, making sure that protein is taking up a lot, protein and vegetables and fruits, really taking up a majority of your plate. And then that pasta, rice, breads, potatoes, all of that stuff is coming to a smaller portion size. Okay. So that's kind of how we talk about it. And then eating off of a smaller plate kind of seems kind of silly, but we know that it's just a psychological thing. If we look at a plate full of food, if we have a big plate full of foods, we're going to have more calories. And if we put and we have a small plate full of food, it's going to be less calories in the big plate, right? So we're automatically going to intake less on that smaller plate. But the psychological piece is if we put that same amount of food on that small plate now onto that big plate, the plate doesn't look as full. And we think we're not going to be full with that small amount of food. And it's completely psychological. However, if we if we see that plate full, it makes us feel like that amount of food is going to fill us up, even though it's on the smaller plate and it's the same amount of food on the big plate. It's just this psychological game we play. I had a patient tell me, if you eat off of a yellow plate, then it also helps make you feel fuller faster. I don't think there's any research around it, but the small plate thing is something that evidence has kind of supported. The other things that evidence supports is using a food journal. There's apps now where you can kind of actually just take a photo to keep track of what it is that you're eating. I love that because it's just a great way to start, like, hey, what are you eating? Like, it's so easy to forget what we ate throughout the day, even though we think we remember those things. We actually don't. Kind of forgot about like the cupcake that we grabbed over in the break room during so and so's birthday, stuff like that. We kind of forget about that stuff when we get home, and we might have another sweet dessert after or whatever. So it's always good to journal what it is that you're taking in. Apps make it easy, but you can also just go to a handwritten journal and a little notebook that you carry around. Mediterranean diet, so just kind of eating like you live around the sea is how I tell patients about that. The DASH diet, low sodium, really heart protective. And intermittent fasting does have evidence to support its efficacy in decreasing visceral fats, especially. So all that fat like if you have somebody with the fatty steatosis, hepatitis, they just changed that name. But it's no longer, it used to be called non-alcoholic fatty liver disease. We have now switched, and now I'm forgetting the name. But if somebody has that, intermittent fasting could help with that. All right. Any questions around diet here? Okay, I got to keep moving because I am getting behind. Physical activity, super important. We can use that exercise prescription, so actually writing it down. I love the extrinsic feedback from a pedometer or like a smartwatch. It just tells us like, hey, did you close your rings today, or whatever brand you choose. Can give us some motivation. It's silly, but it works. I always tell patients, keep track of your screen time. That's TV time, computer time, phone time. Try to limit that down, right? Can we just get off the screens a little bit? It will probably increase our movement. Okay. The goal is 150 minutes of moderate intensive activity per week, and at least 2 to 3 days of resistance training. We know how crucial resistance training is in the maintenance and also the production of lean body mass. Lean body mass is directly related to our basal metabolic rate. So how our body utilizes energy when we're not doing anything but just existing. If we have more lean body mass, we will have a higher basal metabolic rate. And resistance training 2 to 3 times a week, 10-minute sessions, have evidence that it supports so much benefit. Okay. We also think about sarcopenia. If we're using GLP-1s and GIPs, that class of medications, there's been a lot of information coming out about sarcopenia, or muscle wasting and bone density loss. So resistance training is key when we are prescribing these medications for our patients. They need to understand how important it is to reduce fractures as they age, okay, and keeping that lean body mass or increasing it. We don't start with 150 minutes of moderate to intense activity with all patients. We meet them where they are, and we create a plan based on where they are. If they're having a difficult time just moving around their house, giving them an exercise prescription of 150 minutes per week is not going to work. Okay, so I have a patient, for example, who lives a very, very sedentary life right now, limited by weight, limited by knee pain, back pain, lots of chronic pain going on there. And just talked to him yesterday, our goal for this next 2 weeks is doing simple activities of getting in and out of the chair slowly, okay? And why are we doing that slowly? Because when we sit down and it doesn't feel good, oftentimes we plump down into our chair and we have no control, and our muscles are kind of losing some of that memory. And so what we work on, and it's not even getting all the way out at this point, his task is to get his bum just half an inch off the chair, okay, using his arms and his legs at the same time. Okay, with somebody like that, physical therapy is so crucial, and I'm trying so hard to get him to buy into the physical therapy piece. I oftentimes work with patients, work with physical therapists in conjunction with weight loss because a lot of folks are not ready to move into something, and what could happen is an injury, and we want to avoid that. So, oftentimes, personal trainers are really great ways to personal trainers or physical therapists will help us quite a bit with developing an activity kind of prescription that will keep our patients safe and keep them moving forward. So the last thing we want is that we do something and we cause an overuse injury, and now we're back to square one and we can't do any physical activity. So we're going to go super slow. Oftentimes, I'm not really having too much conversation around physical activity other than that resistance training piece um, when we're starting medications, because I know that my patient is going to be more likely if I give them just a couple of months to just lose 10-ish pounds, they're going to have this intrinsic motivation to start moving more, and it's going to feel better to start doing more activity. So I'm not super strong on the physical activity piece right out the gate. Kind of give it a little bit of time. All right. Any questions around physical activity? I think the most important thing is that we are getting resistance training. I tell patients, even if it's a can of soup, getting some curls and getting some tricep things in with a can of soup is going to be better than nothing. Okay. So you don't need to go out and spend a ton of money at the gym, but I need you doing some work on that, whether it's a wall sit, leg raises, stuff like that, where we are putting some resistance against those muscles, which then will create the bone to stay strong or get stronger, depending on where we're at with that. All right. And that is prevention of that sarcopenia, loss of muscle mass and bone density. Critical things. Okay. So behavioral modification. Um, really important here that we address this at a slow rate and again, at the patient's kind of pace. All right. So we want to um, make sure we don't have any of our own biases. So check with yourself, what are your biases around this? And try to address those and kind of come to terms with some of your own biases so that you can better meet your patient where they are. When we think about behavior modification, I think a lot about stress and the way that we manage stress and what works to manage stress for this patient. Some interventions that I have my patients do around stress management is what makes you feel good? And I'm sitting there while they're there. I have a piece of paper out and they tell me things that make them feel happy, things that make them feel good. And it's simple things, reading a book, calling this person, very specific items, going outside for a walk, going to a certain location, listening to a certain song, all of these things. And I write that for them. And I say, my writing's not good. So I say, if you want to, transcribe this, go ahead. But what I want you to do is keep this somewhere that's visual, that's readily, that you can see. And so when you're having a very stressful day or a low motivation day or you're feeling down, I want you to do those things that you know make you happy. This works for depression and anxiety as well. But that's something that I also have conversations around with my patients. The next thing we think about is sleep optimization. And I talk about how much sleep people are getting, snoring. Do we think that there's a sleep apnea occurring that we need to address, right? Do we need to be on a CPAP? Because if we have sleep apnea occurring, we know that we are now getting into an adrenal and cortisol kind of cycle here, and that can cause weight gain in and of itself. Psychological support. I love when my patients are seeing a therapist. And if they're not, and I think it would benefit them, I go ahead and try to connect them with somebody because a lot of obesity can have an emotional component. We have things like, like growing up, we have these interventions of like you get a shot and at the doctor's office, I don't know about you, but we used to get suckers after we got these shots. And what we're kind of tying together is that we can soothe our our physical pain with something like a sweet sugar, right? And we're getting that dopamine release, and now we've created this coping mechanism. And that can transfer all the way through adulthood. And so when we're not feeling great, or if we hurt, or if we're sad, we may be using food as an emotional support, right? And it's not your fault. This is just the way that it works. So when I have a patient that comes to me and we think about that, we also talk about, well, if we're going to take away that coping mechanism, what are we going to put to um, to replace it, right? We need to put something there. And I actually had a patient drop out of a weight loss program recently because he wasn't ready to let go of that piece, and that was just something that he didn't realize how important it was in his life at that time. Wasn't quite ready to talk about it, and just felt like it wasn't, losing weight, and that wasn't a priority in his in that moment in his life, and that's okay. That's the conversation that we say, like, I get it, come see me when we're ready. Like, I'm here for you whenever you're ready. Come back. The SCOFF is a questionnaire around eating, disordered eating. So something that you can just kind of give to every patient. It's just a quick screening tool. And then motivational interviewing. I think of motivational interviewing in the way that I use motivational interviewing is really helping my patients set kind of those SMART goals. And so I'm not setting goals for my patients. They're setting their own goals. I'm asking the questions to help them get to those goals. Okay, I have to keep moving because we are running out of time. And you guys came to talk probably a majority about some of these medical management things. Okay, so we think about anti-obesity medications. That's what's all over the news. That's something that what we really, really can utilize in primary care. And I am going to tell you, please learn more about these medications so that you feel confident offering these to your patients. All right, so we think about these phenotypes of obesity. We can think look this up. This is kind of some interesting research, but we think of hungry gut, hungry brain, the slow burn, and the emotional coping. And we can kind of categorize obesity into those four. And I'm sure I know there's a lot of overlap that occurs between those. So you're going to have people who may have a little bit of all of the above, right? But what this helps us kind of do is guide some of our treatment options based on what we think is going on with our patient and why they're here sitting in front of us today. All right, if your patient already knows if they're at risk, if they have other issues, if for some reason you don't feel confident in managing their care in the primary care setting, refer to our obesity medicine specialists. You guys, they are out there, they're willing to take on these patients, and they are so good, and they have the full service available for patients. I've definitely educated myself a lot around this. And if you feel like this isn't something that you're, particularly of interest in, you can use that, and please offer that to your patients. There are folks, MDs, NPs, PAs, all of the above, who sit on these wonderful teams that can really help give a full, holistic approach to help our patients. Okay, if you are going to prescribe, we're going to talk a little bit about these different medications. So we have these prices here. I'm just going to go ahead and say it. These are brand name prices, okay? If you prescribe generic phentermine and generic topiramate, or generic bupropion and generic naltrexone, you're not going to have these price points. This is the Contrave. That's the brand name of this medication, and I think the price has actually come down since this was published. This data was published that I used as a source here today. I think these prices are coming down. So don't quote these exactly, but they are. There's an ability for you to prescribe phentermine and topiramate separately, and they're going to take them together. You can mix and match a little bit of these obesity medications as long as you're not using things from the same class of medication. So, if you have some things like the emotional eater phenotype, if you think that our emotional coping as a big piece of what's going on here with your patient, you could go ahead and start with something like a bupropion naltrexone. Here are your contraindications. We think a lot about the seizure disorders because that bupropion in the medication is going to lower the threshold for a seizure and increase the risk of seizure. Okay. Anytime we're using it is an antidepressant with an opioid antagonist. So increase that risk of suicide ideation in younger folks. So just something to consider. If you have a patient who is recently on opiates or has a history of substance use disorder with opioid use disorder, that's a contraindication because the naltrexone is an opioid antagonist that would precipitate a withdrawal right away. Not feel great. Okay, take a screenshot of this. You're going to go ahead and you can increase those doses as needed. I do about an every 4-week kind of evaluation on my patients, make sure their blood pressure's under control, their heart rate's under control. With both of these medications. With topiramate, this is a teratogenic medication. So when I think about topiramate and I think about a patient, I have currently a female who came in and she said, I don't even worry about it. She was like maybe 35 and she said, I've been having unprotected sex for 10 years and there's no way I can get pregnant. I don't know why, but the doctor told me I couldn't get pregnant. I still want her on a very, very good contraception. And the reason being is that when we lose weight, it increases some of that hormonal regulation. And we can actually, if somebody has like something like PCOS that might be undiagnosed or diagnosed, losing that weight may precipitate an ovulation and might get that ovulatory cycle back onto a normal, more quote unquote, more normal cycle. Therefore, it's really important that patients are paying super close attention to that. Okay, 1 second. Something just came in the chat here. Okay, great. All right. And then 5 to 10%, I think that we can achieve a little bit more. With the phentermine topiramate, it's off-label use to go beyond 12 weeks of use. So if you look it up on UpToDate or something like that, they're going to say to stop it at 12 weeks. However, in obesity medicine, we are using that long term. And it is considered quote unquote off label. So it's good to have a conversation with your patient. We think it's safe and it's effective. We consider obesity a chronic disease. We're going to treat as long as we need to. Okay. However, if it's not working within the first 12 weeks, we're going to go ahead and discontinue that treatment. Okay. So if you have a patient that has no weight loss in 12 weeks at the maximum dose, I would go ahead and consider it a non-responder. Unfortunately, your body's not responding to this medication the way that we thought it would. We can try other things, okay? And that's where we have that conversation. It's never like, okay, you're non-responder to this, let's just give up. We sometimes need a combination. We need to talk about some other medications that they're possibly taking. It's a more of a conversation than just like, oh, sorry, I can't help you. Okay, and the big ones. Okay, exciting stuff here. These are the semaglutide, tirzepatide. Some people pronounce that differently, semaglutide, I think I've heard. When I think of semaglutide, I break this down. Semaglutide and tirzepatide, those are the active ingredients in these two different types of medications, okay? Semaglutide is a GLP-1 receptor agonist. And tirzepatide is a GLP-1 receptor agonist with a GIP. So it has two different kind of active parts to it versus semaglutide. Tirzepatide came out afterwards, shows just a little bit more weight loss efficacy, although I think they're pretty similar. I do have certain patients who respond to tirzepatide better versus semaglutide and vice versa. It's just kind of like a trial and error kind of approach. Okay, so these guys, when we think of the active ingredients, we think Wegovy is going to be the FDA approved weight loss medication. I think weight loss. And then Ozempic is our FDA approved semaglutide for the management of type 2 diabetes. When we think of these two medications, they have the exact same active ingredients in them. They work very, very much similarly. The doses do change very slightly. Ozempic goes up to a 2 milligram max dose. Wegovy goes up to 2.4 milligram max dose. So if you have somebody who is diabetic and you can get insurance approval for Ozempic because of their diabetes diagnosis, you can increase their dose a little bit, but you're going to see that on the pen it does max out at 2 milligrams. So you have these fancy little pens here. I think we may see some change in how they're dispensing these medications. There's a huge shortage. Because of that shortage, there's the compounding pharmacies that are producing that. The concern around compounded products is always sterility, potency, and just safety in general. So something to talk about with your patients about, because they probably are, if their insurance does not include cover these medications. As you can see, the price is pretty high. I think they've come down a little bit from this again. However, the prices are fairly high. So that compounding may seem a little bit more tolerable, or, like, they might want to go that route, but just be careful around those things. Again, after 16 weeks, if we don't see any weight loss, and I'm hoping that we're at that max dose, if they don't lose any weight, then we're going to consider them a non-responder. Again, that doesn't mean we just stop all intervention. We just consider some alternative interventions, other medications that we could consider. Tirzepatide, the weight loss Zepbound is our weight loss approved medication, and Mounjaro is our diabetes approved medication from the FDA. Again, these contraindications, very few contraindications that we see here. They're the same for both medications. And then if they're type 1 diabetics, then we wouldn't use this medication for them either. Most common side effects are nausea, vomiting, just GI in general. I always make sure that my patients' triglyceride levels are within a normal level before starting these medications, to decrease the risk of precipitating like a pancreatitis or something like that with high triglyceride levels. So less than 500 is a requirement. I tell patients, if it's above 500, we'll just work to get it down, and then we'll start the medication. But we won't start it if the triglycerides are 500 or above quite yet. Okay, these medications work really well. We titrate every 4 weeks. It's an once a week injection, super easy to dial. I suggest calling the rep and getting some sample pens so that you can know how to do this and teach your patients how to do the injection correctly in clinic. I do use these often and have seen really huge benefits. The biggest thing, again, is going to be that resistance training to maintain or prevent a sarcopenic state, so that loss of muscle mass and bone density. So those are really important. If patients are having a lot of nausea, vomiting, bloating, diarrhea, any of those things, I tell them mostly it's related to either what they're eating, how much they're eating. So if we can just decrease consumption, and you can do more frequent things, and then really minimizing sweets and carbohydrates and stuff like that, because those seem to make us feel worse when we're taking these types of medications, just because of the way the medications work in our body. Okay, surgical procedures are out here. Again, the different things that we see mostly here in the United States. There's other things that we see outside of the United States. These are all going to be performed through an obesity specialist. So really important to know the names of them, kind of why, when, who would we refer what we expect for weight loss with these different things, with these different procedures. They are effective, but then you may have somebody who has this procedure and gains weight afterwards. We could use medications for those patients. Okay, I'm sorry we don't have time to get to my case study today. It's been a pleasure talking with you all. I hope you have a wonderful day and that you feel a little bit better about addressing obesity. It's so important and it's really fun. It's probably the most rewarding thing I've done in primary care, I have to say, because we see such great outcomes. So familiarize yourselves with these medications, and if you have any questions, you can email us. And please, if you haven't already, register for our live review coming up if you're sitting for your boards.
Sorry, Morgan, I hate to interrupt, but
okay.
the CCRN team needs to
Along.
Zoom now. So
See you guys.
we'll let everyone take a screenshot of this, and we will see you guys on the next live webinar.
Take
Thank you,
care,
guys.
guys.
Thank you, Morgan. Awesome lecture today.